Searches for how to lower cholesterol fast, LDL versus HDL, and do I really need a statin are trending, especially as we age, and for good reason. Heart disease is still the leading cause of death, yet cholesterol remains one of the most misunderstood topics in health. Is cholesterol always bad? What do your numbers actually mean? Are the medications like statins the only solution, or just part of the picture?
Today we're cutting through the confusion with the top expert with advanced credentials, Dr. Michael Horn from the University of Colorado Anschutz College of Nursing.
Thank you so much for joining us today. We really appreciate it.
Sure.
All right, we're going to go into the big question, what everybody's talking about. What is cholesterol?
Sure. Good question, because it's a term that's thrown around broadly with probably a lot of different assumptions on the definition. So cholesterol itself is just a fatty, waxy substance that's in the body. It has beneficial functions and non-beneficial. The way it's transmitted through the body is through what's called lipoproteins. And so that's where we get that term LDL and HDL. LDL is low-density lipoprotein. HDL is high-density lipoprotein. What that really means is one of them is good, and we'll talk about that, and one of them is bad, but that is what actually carries cholesterol through our bloodstream. In the bloodstream, cholesterol, if it just goes through, doesn't really cause any problem, maybe go to some cells that need it, etc. But what can happen is those LDL particles can get lodged into basically the wall of our arteries, and that creates a fatty streak. So you think about it, it sort of blocks the flow of blood in the artery a little bit. And what the arteries carry is oxygenated blood to our muscles, our brain, our heart, everything that needs it. So that reduces the flow a little bit. Now, that on its own typically doesn't cause significant problems. It can as it builds up. What the big issue that it causes is that fatty streak can sometimes rupture. And it basically acts like a bleed that you have when you cut yourself. And what the body does when you bleed is it clots, right? It wants to stop the bleeding. Well, it does the same thing with the fatty streak in the artery. And unfortunately, if that's in a coronary artery, so the arteries that are feeding your heart oxygenated blood, it causes a clot, and then the heart doesn't get that oxygenated blood, and the heart's a muscle like anything else. If it doesn't have oxygenated blood, you have a heart attack.
Oh, wow.
So that's why cholesterol is kind of important, sort of broken down into how it's transmitted and what it does.
Okay. Well, and that leads into our next question, kind of the big debate. Is cholesterol really good or bad, or is that kind of an oversimplification?
Yeah, definitely an oversimplification. You know, our bodies do use cholesterol for some beneficial purposes, but the amount that's in the bloodstream really is not beneficial. So we have guidelines in terms of numbers and in terms of risk, and we'll talk about those. But really at a base level, any LDL in the bloodstream is not necessarily helpful. So we do want to get that minimized. And again, we don't go to zero, not that that would actually hurt anything, but that would be a little bit unpractical. Cholesterol itself as a thing has some beneficial purposes. It's just that for most of us, we have too much of it.
Yeah. Especially the way I think, our diets are across the United States this day. When you're talking about blood levels, what blood levels are important to measure and kind of explain what they mean?
Sure. And this is a great topic because there's some changes coming. There are going to be some new guidelines coming from the American College of Cardiology in a couple of months around cholesterol management, lipid management. And one of the things will be some new measurements. So traditionally, what we've done is we've measured total cholesterol, and then with those LDL particles and those HDL particles that I mentioned. We want the LDL particles to be lower. We want the HDL particles to be higher. And we don't use an exact number. We pull in a lot of risk factors in addition to the number in terms of LDL. But in general, you want it below that LDL number, below 100, or if you've already had a heart attack once, below about 70. What we've learned is that in addition to that, a better measure perhaps of cholesterol is something called apolipoprotein B, big name, ApoB.
Yeah.
What it does is actually measure the number of LDL particles. Our old LDL measure just measured the amount of cholesterol in the LDL. Now, intuitively, you might think, well, wouldn't that be the more important measure, the amount of cholesterol? That's the problem. As it turns out, it's the actual number of cholesterol-carrying particles that are more damaging. So that ApoB measurement is probably more accurate than the LDL. So I believe over time, we may start doing both. We may eventually replace LDL with apolipoprotein B. That's one new measurement. So to confuse things, we have another one.
Great.
we've known about this for a long time, but we didn't really know how important it was. There's a product, another particle called lipoprotein A, LP little a. People may have heard this. They may have already had it measured in their doctor's office because they're doing more of that. So what that is, it's a type of LDL, type of the bad protein, but a lipoprotein, but it has an additional particle attached to it called apolipoprotein A that causes it to be even worse in terms of cardio risk. The interesting thing about these LPA molecules and the number of them, they are totally genetically determined, or almost totally, and they are set by about age 5. Unfortunately, unlike LDL, which we'll talk about, which you can help with diet and exercise, the LPA is very unaffected by lifestyle. So that's a challenge, and it is a strong additional cardiovascular risk factor. There are drugs in the pipeline right now to manage LPA. We expect them to be out later this year. Until then, the normal things that we'll talk about for lifestyle management, using statins if you have other risk factors, help. Statins don't reduce LPA, but they help reduce overall cardiovascular risk. So those are two new things that I'd be looking out for. LPA, which people may have already gotten measured by their provider already. That one's been out there for a year or two. And then apolipoprotein B, which is kind of the newest one that you'll probably start seeing your providers measure, especially as these new guidelines come out.
Yeah, so things really are changing. I mean, this is sudden, and this is because I have not heard about either of this before, even going to my doctor recently for my annual wellness checkup.
Yeah, and I would say the current guidelines from the ACC, American College of Cardiology, recommend those sometimes only as additional risk factors if you're like in the gray area of starting a statin or something like that. But overseas, the European groups and the U.S. National Lipid Group actually do recommend LPA measurement once in everybody's lifetime. So I do anticipate that changing with the ACC one in a few months. And so likely throughout this year, people, when they go into their provider, will start getting that measured. Because it is an independent factor that we will be able to do something about more in the future than we can now, but at least we'll be able to do something about it. So, that's one factor, right? LPA, LDL, or ApoB, whichever you measure. The way we sort of treat, though, cholesterol is different than we did, say, 15, 20 years ago. 15, 20 years ago, we tried to look for a total number and get it below this total number. It used to be 200. Well, we learned, number one, that the total number is not really the important. It's the LDL and HDL makeup. The other thing we learned is that, there's so many risk factors that can affect cardiovascular risk that, as opposed to targeting a number and just looking at cholesterol, we have to look at all those factors. So whether you have hypertension, whether you're overweight, whether you have diabetes is a huge one, and your age, we roll all these together, and there's a calculator, a new one they're using now called Prevent, that gives you an estimation of your 10-year cardiovascular risk. What's your risk of having an event in 10 years? And based on that, that's really more of a driver of when we want to start treating things like lipidemia, hypertension, et cetera. There are some cases where you absolutely should treat lipids with a statin, for example. If you've had a prior heart attack, if you're a diabetic over 40, if your LDL cholesterol number is really, really high to begin with. Otherwise, we roll in this risk calculator to look at all those factors, because cholesterol is only one factor out of a whole bunch that can affect your cardiovascular risk.
Okay, and speaking of statins, I mean, are we now with the new kind of information and guidelines out there, are we seeing that statins are working? Are they overprescribed? It seems like this is going to be changing, how they're prescribed.
Yeah, good question. Now, and what I would tell you for the people that are not statin fans, though, they won't like the answers much, because my guess is in the new guidelines, there'll actually be even more indications.
Really?
And more use.
Okay.
So the deal with statins is that because they're so prevalent, right? Because a lot of people have risk factors in cardiovascular disease. You get a lot of information about them, a lot of opinion that is not necessarily fact-based. So let's start off with, first of all, kind of what are they and why we use them. So statins basically reduce LDL cholesterol in your body. They do it through a couple of mechanisms of reducing production in the liver and increasing the amount that's taken out by the liver. There are other medicines that do the same thing if you can't take statins, or sometimes you need to add to them some newer ones, but they're the first line. The thing about them that is really powerful is that they don't just reduce LDL. That'd be nice, but does that really make a difference? So what we have just many, many, many studies, right, that show on average, they will reduce your cardiovascular risk about 20 to 30%, which is a big number.
That's a big number.
Now, if you've already had a heart attack, your absolute risk is already higher. So 30% of that bigger number is even more important, right? But for somebody that hasn't had a cardiovascular event, it's still 30%. Even if their risk is fortunately not as high to begin with, it's still a nice reduction. So I'm a cardiology guy, so I am a big statin fan.
Yeah.
But mainly because I know the data, right? There's so much positive data. And honestly, it's been the biggest thing that has reduced cardiovascular disease and death over the last 20 years. It is the most important medicine we've ever developed by far.
Interesting.
Now, let's talk about the things out there what are the negatives, right? Because any medicine has side effects. So the primary thing that people will experience sometimes, about 5 or 10%, it depends on the person, depends on the type of statin, is muscle pain, some muscle soreness. When you do detailed studies, you find that only about 1 or 2% of that is related to the medicine. The other percentage may be related to other things going on. But nevertheless, it's a real percent. We can help manage that with the way we change statins, maybe dosing, maybe some CoQ10 supplement with them, which actually helps reduce that pain. But that's real. The second thing that's real is that there can be a very small increase in what's called your A1C, which is your average blood sugar level. So someone that is pre-diabetic, it might push them a little bit higher toward diabetes. However, the interesting thing is that diabetes, unfortunately, is such a cardiovascular risk that the benefit of taking a statin for someone who's diabetic or pre-diabetic far exceeds that little small increase that the statin may do. The third thing is that in a very, very small number of people, it can cause liver damage and a condition called rhabdomyolysis. It is a very tiny percentage, but it's important because when you start somebody on a statin, you want to give them education about what to look for just in case that type of thing happened, right? And check it. Those are the only valid, true, proven issues. There was some debate about, does it cause dementia? Well, they did studies and it actually shows that it reduces Alzheimer's risk. Statins actually reduce Alzheimer's risk. There's been other things, all kind of things thrown out, but none of those really have any basis in fact. And when I deal with patients, I try not to be judgmental about what they've read or heard. I just give them data because that's, whether it's a vaccine or a statin or anything else, data, I think, is the way we should handle these things.
Yeah.
In terms of, so that's the take on the statins. I mean, the reality is, the other thing that people ask a lot is, well, can I just use lifestyle to fix my cholesterol problem? And the answer is maybe. So what we've learned is that about 60%-ish plus or minus of your cholesterol levels are hereditary determined, basically how much your liver is going to make. So that percent you can't do a lot about. You're born with it. About 20% is diet and lifestyle. So that's a nice little chunk, right? If your cholesterol level is only 20% higher, you can totally fix it by diet and lifestyle. And then the other 20%, so we're up to 80 now, right? So get to 100. The other 20% is insulin resistance, diabetes type things, weight, and menopause. Because menopause does increase cardiovascular risk and LDL levels. It's not one of the biggest factors by far, but it's part of that additional 20% going in there. So the point of that is, you can be a marathon runner and be the most healthy person in the world and still need a statin if you were just born with a liver that produces a little more. I'm sure that would be frustrating in that case, but it is the case. On the other side, if your cholesterol maybe is just a little higher than it needs to be, and you take some aggressive lifestyle changes, you may not need a medication.
Yeah, and let's talk about those lifestyle. What are some of those lifestyle changes people can do to help reduce that cholesterol? Because I know for me, I have changed the way I eat. I've really cut out the white sugars, the white processed carbs, and my LDL cholesterol dropped dramatically. And I'm eating a lot of proteins that I might consider higher fats, chicken and some red meats, but my LDL cholesterol actually dropped by cutting out. Now, I don't know if that's the case for everybody, but that worked for me after going through menopause.
Yeah. So first of all, you make a good point. Medicine is very variable per person.
Correct. Yes.
I had an original career as an engineer and we had formulas, right? And everything was always the same. Medicine not that way. What is supposed to happen doesn't always for somebody. So we do have to realize there's a whole lot of variability, that what you do works for you, might not work for some, might even work better for others. So there's a lot of factors going. But yes, we absolutely want to encourage lifestyle changes, not just for cholesterol management, but for the broader risk, reducing the risk of cardiovascular disease and Alzheimer's and a whole bunch of other things. So important things to do. I remember back when I used to watch Dr. Oz 20 years ago when he first started, and he had a little joke that, if you're a smoker, just don't worry about the rest of it. it's
Yeah.
going to kill you.
It's all
So, if you're smoking, stop. Second thing, exercise. So we target about 150 minutes a week of moderate, at least exercise, both some aerobic and some anaerobic. So some resistance training and some, aerobic walking, running, etc. That's important. Diet, then, as you said, the big things that we see from a cholesterol standpoint is saturated fat is a problem. Now, that doesn't mean you can't eat protein. Even the new guidelines that came out, which I think I like in general, but there's a little bit of concern. It mentioned lean protein. So that says not necessarily a lot of red meat. I eat red meat, right? I eat it about once a week, maybe once a week or two. But lean proteins like chicken, like you mentioned, salmon, that kind of stuff are fine. They're great. But not a lot of saturated fat if you can. Absolutely the point you hit, refined, ultra-processed foods and refined sugars. We've learned more and more how detrimental those are to us over the last, 10 years or so. So that is a huge one. And then just in general, I would say the Mediterranean diet is a good thing to look at if people want kind of a simple way to look at things, which is, it emphasizes lean proteins. It's not totally vegan or vegetarian, which is fine too, but that one emphasizes lean proteins. It emphasizes fruits and vegetables, and there's not a lot wrong with any of that, because in addition to just the value of the nutrients themselves being more positive, typically people will have better calorie control on those type of diets. They'll lose weight, because weight is really more about what's coming in and what's going out, not necessarily the mix as much. It's just total calories in, total calories out. And so that causes a reduction. So those are the things that people should do. And again, even if that doesn't reduce your cholesterol to the point that you still may need a statin or another cholesterol medicine, it still has a huge help across all the cardiovascular risk.
Well, and you just start to feel better. You just,
Yeah,
for
absolutely.
me, good point there. I need to cut back. I don't do a ton of red meat, but I do, some red meat. So maybe now my next step is switch out that red meat for more salmon or more fish. And really, it's interesting because I love eating sugar and I love eating white carbs and gluten and while I'm eating it. But after now, if I eat it, I feel awful. So you
Yeah.
notice that over time, you just start feeling better when you eat cleaner. And so I think
Yeah.
that's good points all
Well,
around.
and our bodies are programmed, right, from
Yeah.
caveman days to get those high energy carbs in so we had energy. Because back then, starving was the issue, not and being able to run away from the tiger, right? Well, we haven't had that issue for most of the people, fortunately, for a long time. And I think you're exactly right, though. At first, the change is a little harder because there's a craving for
Yes.
the missing. And then it gets to a point where actually, it doesn't make you feel good
You just don't feel
when
good.
you eat it. The other thing I'd say about red meat, and again, I eat it. I'm not an anti-red meat person, but in addition to maybe not as frequently, the other thing that I've found, especially as I gotten older, is lower quantity, right?
Yeah.
So not that 8 or 12 ounce steak, but maybe that 4 or 6 ounce piece of meat. Enjoy it. Have that great taste you like. Don't feel bad afterwards, right? Because you're not used to eating red meat. And it's not at a level that probably is going to be causing a lot of problems. And then there's clearly some good things about it, right? There's good things about strong proteins going to your body.
All right. Well, Dr. Michael Horn, thank you so much for joining
Sure.
us today. Great insight.
Thank you. I really enjoyed this kind of education because I think if we can get more of that out there, that's the way to solve our health problems, not more medicine, right?
Yeah, just people understanding and taking action and really just kind of taking charge. That's the one thing I noticed, just really making an effort. We put so much into the lives of our kids and everyone else around us, our work. We really have stopped taking care of ourselves. And if we just think of it like, I'm going to take care of myself like I take care of everybody else, you start to feel better all around.
Absolutely. Absolutely.
Thank you.
All right. Thanks.
Next time, in part 2 of our conversation, think your cholesterol management should slow down over 50? Think again. Next time, we talk about how cholesterol management after menopause isn't just about age, it's about risk, and how simple lifestyle changes can change everything. Be sure to follow and subscribe for more ways to stay healthy so we can experience more of what life has to offer.